Hello everyone, second part of our today MSK-Viva session. 25 years old female patient have an ankle swelling.
I'll start, sir.
Start. Yes,
Yes, provided is the frontal radiograph of ankle in a young patient. So there is an expansile lytic lesion involving the meta epiphysis of the distal tibia, involving the medial malleolus. It is eccentric with coarsen trabeculation and cortical thinning. Tibiotalar joint is paired. It is extending till to the joint surface, and no significant periosteal reaction. Soft tissue swelling is noted. No other focal bone lesions are noted. So I'm thinking in the first differential, I'm thinking is a giant cell tumor. That is first differential. Second is an aneurysmal bone cyst. So I
what
would
will you
convey
do
this
next?
finding, sir.
What will you do next?
I would convey these findings to the orthopedician and get an MRI for this patient.
MRI of the same patient?
Yes, sir. Axial images, uh, fluid fat sensitive sequence, fat suppressed sequence, or coronal images.
Mm.
I can see a hyperintense lesion involving the meta epiphysis of the distal tibia, uh,
Yes,
with thickened septae and surrounding significant soft tissue edema. It is extending till to the joint surface.
yes,
I'm not seeing any fluid levels in this.
yes.
So I'm thinking. So first differential is a giant cell tumor. I would
Mm-hmm.
also see the
Yes,
I would also see the SWA sequence for any hemorrhagic component. So T1 also has hyperintense signal, and
yes.
T1. So I'm thinking of giant cell tumor and aneurysmal bone cyst. So I'd convey these findings to the orthopedician and discuss
Which in
in
the
bone
top of
tumor.
your, which one is in the top of your differential diagnosis, please?
Yes, sir.
Which one is in top of your differential diagnosis?
So first is aneurysmal bone cyst, sir.
What will you do next?
Sir, I would convey these findings to the orthopedician and call for a bone tumor MDT for further evaluation and discussion.
25-year-old female with abdominal pain.
Okay, sir. So provided is the frontal radiograph of abdomen with a young female with pain abdomen. So I'm just taking a look before I comment. So the first thing I can notice is two prominent horn-like projection, which is seen along
Excellent.
the bilateral iliac bones, which is in keeping
Excellent.
with bilateral iliac horns.
So,
And I'm
what's your
seeing, so
what's your diagnosis?
my differential is Nile Patella syndrome. But also ask for the patient if whether the patient has any lack of patella in the knee for
Okay.
clinical examination. Uh,
Excellent.
I would con- and I would convey this
What
finding.
else? What examination want you? What do you want to do also?
So come again, so please.
Which part of the body want you to take another X-ray for this patient?
So another, I would also ask for if there is no previous radiograph. I would ask for radiograph of knee, sir, knee AP and
Knee.
lateral to see to confirm the
What else
absent
other
patella.
than the knee? What else other than the knee?
Come again, sir.
What other joint want you to image it other than the knee?
But also, I would also look for the elbow, sir,
Excellent. There
elbow.
are any other association of chronic disease with this nail patella syndrome?
Um, Nail, but I'm not able to make sure, sir.
Excellent, doctor. You did very well. I give you 7.5 in last case. This is a nail patella syndrome, and this is an observation film. Take care, my colleagues. The examiner may bring one film with a history of like a pain, abdominal pain, and the diagnosis is here, and this is something not related to the complaint. Bilateral iliac cord. The most important, I bring this case to explain or to ask about the association. Why? There are hypoplasia of the patellum and the
Yes.
capitellum, and the resultant subluxation or dislocation, either of the elbow or the knee. This is very important. Another
Mm.
very important association is a renal osteodystrophy. Very
Okay.
important.
Yes.
Okay. This case, doctor, you did very well until I came here, and I'm going and come. This is a soft tissue here.
Okay.
So
Okay.
I ask you, which one could you put on your top, in your top of differential diagnosis? See, this is a soft tissue. So
Mm.
you must put a giant cell tumor before, you must put a myeloblastoma or giant cell tumor before aneurysmal bone cyst. This is very important. And
Yes.
like this, you are in another way. Aneurysmal bone cyst overall is a benign condition, but
Mm.
giant cell tumor is a locally malignant condition. So we must, and second point, you didn't talk about this cortical break.
Mm.
Take care, my friends. There are many fine details you can collect marks from it. The exam case almost is a usual case, but as you know, stress destroy many of our information. What is our
Mm.
next step? You tell it very well. You must transfer to bone center. But I am waiting from you to give me more and more differential diagnosis, like
Okay.
chondroblastoma, but the epiphysis is closed. Or
Mm.
you should tell me it may be a brown tumor if the patient is a chronic renal disease. And last thing, chondromyxoid fibroma, but chondromyxoid fibroma is a metaphyseal. My friends try to use the golden F. Yeah, like you should tell me the differential will be like this if, and I will exclude this diagnosis because of this the lesion is contain. I will exclude APC because the lesion containing soft tissue like this. Okay.
Yes. Yes.
This case is a 2-minute case. Why? There are sclerosis here.
Yes.
You pick it up well, and then you go to both sacroiliac joint. No, sacroiliac joint in 60 years old patient is very good. خلاص,
Mm.
concentrate here. I see
Mm.
sclerosis. I suspect, at least in me, I suspect there are coarsening of the trabeculae and the thickening of the cortex. Next step is
Yes.
CT, better. The CT
Sure.
here confirming a diagnosis of Paget. By the way,
Yes.
Paget is a metabolic disorder of the bone, which there are abnormality of turnover. We have 3 stages of Paget: lytic, then mixed, then sclerotic. Okay, Paget is a
Yes.
common disease of elder age. Paget
Yes.
also cause the hyperscan, super scan.
Yes.
Super scan, one of the most common cause, metabolic cause of super scan. Okay,
Yes.
I gave you in this last case budget 6.5 because you delay. Okay, second,
Yes.
my colleague try to use the common buzzword like thick cortis and cortis trabeculae. When you told me like this, I know that you are in the correct pathway. This
Correct.
case also, you did it very well. Okay, but you look here and you start to give me a more description. No, examiner want you to pick up the abnormalities. There are periosteal, okay, cortex second, okay. I want is another orthogonal view. You didn't talk until I show you this, then you change your diagnosis. Oh, this is not a cortical thickening, this outpush. Okay. Second point, I ask you here, I wait you more than 1 minute I'm waiting you to tell me, doctor, please, I want to measure the cartilaginous cap. MRI is doing mainly in osteochondroma for measuring the cartilaginous cap. Okay? If the examiner, if you didn't tell, you lost the MRI. You ask me, I give you this gradient, you can measure from gradient. This one very thin. Okay, you ask for T2, okay. But look here also, there are some edema here. This is called adventitial bursitis due to compression of the adjacent muscle. Okay,
Okay, sir.
but you did very well also. This case also patch it and you pick it up at the last few seconds, but good. See here, this is a known history of malignancy or breast cancer. Okay, but look here,
Yes, sir.
the cortex is intact. Okay, there are lytic lesions, but this is not aggressive. At least you should tell the examiner, I see lytic lesion, thickening of cortex, and the cortex is intact. Okay.
Yes, sir.
Second point, there are corsets therapy. You give me a good differential diagnosis, which include hemangioma, but in hemangioma, the cortex is not thickened. This is the differential point between hemangioma and Paget disease. Thank you, doctor, so much. Third candidate,
Thank you
please.
so much. Thank you, sir.
Welcome. Third candidate, Dr. Moz. Any candidate ready now? دكتورة ميجا، دكتورة حنان. اوكي any candidate ready؟
دكتورة هناء.
دكتورة حنان.
هناء.
اوكي.
أيوة دكتور.
welcome دكتورة هناء.
Yes.
Okay.
Thank you, sir.
35-year-old male patient complaining of a localized posterolateral aspect pain at the knee with reduction of range of movement.
I'm presented with the MRI of the knee in sagittal cuts, T2 weighted images showing multilocular cystic lesion on the posterior aspect of the knee joint related to the synovium of the posterior knee joint and adjacent to the posterior cruciate ligament.
Yes.
I want to see the other sequences. I want to see T1 weighted images to confirm the cystic nature of the lesion.
Don't worry about it. The pathology is here. What's your differential?
There is the thickening also of the anterior cruciate ligament.
Yes.
Yeah,
Yes.
this one. And there is a small rim of fluid signal intensity anterior to the anterior cruciate ligament, with the scanty joint effusion also in the suprapatellar recess. I'm checking the bones. There is no abnormal signal intensity of the bones. I want to check the menisci.
Don't worry about it. It's normal.
Yes, both of them appear normal. I want to check the patella. They appear normal as well, but I note that the bone signal intensity appears to be very low.
Don't worry about it. What's your differential diagnosis?
My differential diagnosis, the multiloculated posterior knee joint cystic lesion, is a ganglion cyst or a Baker cyst.
Okay.
Yes. It could be traumatic, for example, resolving hematoma, less likely.
What about the description you made for the ACL? What's your differential for ACL abnormal signal?
It could be a partial tear or a mucodegeneration of the anterior cruciate ligament.
How could you differentiate?
In the mucodegeneration, the age group will be in the middle or elderly age group. There will be ciliary stalk appearance of the anterior cruciate ligament. Partial tear, there could be an edema in the attachment site of the anterior cruciate ligament.
Excellent.
I'm okay.
35 years old male patient with ankle sprain.
I am presented with the frontal radiograph of the left ankle joint of a young age patient presented with ankle sprain. I can see an abnormality involving the medial aspect of the ankle joint. There appears to be an articulation between the medial aspect of the talus uh, and is that, I think, the medial process of the calcaneus, as if
What will you do
there is
next?
a coalition. Sorry,
What will you do next? What will you do next?
I want to request a CT scan of the ankle for confirmation
No
to
CT
exclude
available.
coalition.
Only X-ray
MRI,
is available. Only
only
X-ray is
X-rays.
available. What will you
I
do
can see the
next?
lateral projection.
Yes. Go lateral.
Yes, yes. In the lateral projection, I can see the C sign, which is
Yes.
suggestive of coalition, tylocalcaneal coalition.
Yes.
I want to
What
just
type of coalition do you know?
the most common coalition, calcaneo-navicular and tylocalcaneal types.
Okay, what is the types? What is the types, not the size of coalition?
Bony
Nature.
or fibrous,
Yes. Excellent.
osseous or fibrous. Yes,
Excellent.
I am.
Excellent.
Okay, sir.
10 years
Just tell me
old
about the
female,
history.
10 years old female patient with right shoulder pain.
I'm presented with a frontal radiograph of the right shoulder of a 10-year-old female presented with shoulder
Yes.
pain. I can note that there is an abnormal density of the and the trabecular pattern of the right humerus, involving the proximal humeral metaphysis and a part of the humeral epiphysis as well, in addition to a large soft tissue lesion that contains foci of calcification. I want to ask about any history of trauma.
No history of trauma.
If there is no history of trauma, I'm suggesting an aggressive lesion with osteoid
Why?
matrix. Sorry.
Yes. Yes.
Yes, because of the age of the patient. First, she is a child. Location of the patient, location of the disease, adjacent to the metaphysis, and the presence of large soft tissue mass with osseous types of matrix calcification. I'm
What
thinking
will you do
about.
next, Dr. Hana?
I request a CT scan of the shoulder. This is a
This is
bone
a bone
scan.
scan. Yes.
Yes, this
Could
is
you
a bone
describe?
scan. This is a technetium 99 MDP scan of the whole body of the same patient. Shows the avid uptake involving the proximal right humerus.
What will you do next?
CT scan or MRI of the shoulder. This is MRI. Mm. In the MRI of the shoulder, I'm presented with the coronal section of MRI of the shoulder in T2 fat-sat sequence, showing
Excellent.
a large heterogeneous signal intensity soft tissue lesion encasing the upper part of the humerus,
Yes.
involving the humeral epiphysis, metaphysis, and the proximal shaft. This lesion has heterogeneous enhancement post-contrast and appears to be encasing the humeral bone, in addition
What's
to
your
abnormal
differential
signal.
diagnosis?
Differential
What's your differential?
diagnosis, differential diagnosis first, osteosarcoma, then
Yes.
Ewing sarcoma.
What will you do next?
I should I also put the differential diagnosis to a lesser extent of infective process, like acute osteomyelitis. Do next management first correlate with the patient clinical condition, history, and lab investigation. Um, uh, Tissue confirmation should be done by biopsy in the specialized bone tumor center, conveying the findings to the referring clinician and discussion of the case in MDT team.
Excellent 25-year-old female patient presented with a traumatic pelvic injury.
I'm presented with axial section. I'm presented with
No,
a
this is
frontal pelvic radiograph of a patient with traumatic pelvic injury. I can note that there is a displaced fracture involving the involving the neck of the left femur, with the migration of the distal femoral fragment superiorly, without dislocation of the femoral head. There is also widening of the symphysis pubis, which is called the open book fracture. I'm checking the iliac bones,
no
and
open book. Not open book.
it's not open book.
What
Okay,
else?
sir.
Yes.
I'm checking the pubic rami and ischial trochanters. I cannot note any fracture. So I request a CT scan for the pelvis, and I'm also note that there is a contrast in the bladder, means the patient
Yes.
underwent a cystogram to evaluate for any urethral or bladder rupture.
What do you think about the size of bladder?
The bladder size appears to be small, sir.
So,
But I
what do you
cannot see
think?
any. Yes, yes. So there is a flame-shaped contrast involving the pelvic cavity surrounding the urinary bladder. So I'm thinking about extra peritoneal bladder rupture.
This is a CT.
Yes, the CT also confirms the findings. Yes, it shows the contracts outlining the bowel loops. So most likely to be dealing with intraperitoneal type of bladder rupture, as it is not confined to the
Intra or
perineum, but
extra?
extends upward.
Give me a definite answer. Intra.
Yes,
Okay.
intraperitoneal bladder rupture. Yes.
Okay, what's your management?
Management, first, in regard to the fracture, I should convey urgently my finding to the referral clinician. I should also note for the presence of any vascular injury, any vascular extravasation, especially of the femoral neurovascular bundle. I should also convey the finding of intraperitoneal bladder rupture for urgent surgical intervention.
Thank you, Dr. Hannah, too much. You did it very well, especially in last case. This last case is a multimodality. The examiner will start with an X-ray. This is the usual. Okay. He will give you something like this. There are transcervical fracture of the left femoral neck, and there are widening only, not open book. Open book should be associated with some abnormality here in both sacroiliac joints.
Okay.
This is you can say separation, and please don't give too much definite diagnosis because the examiner will ask you or will demarcate you. Second point, this is not a plane, this is ascending cystourethrographia, and you can see here the bladder size is reduced, and there are some soft tissue density here displacing the colonic shadows and the bladder. And this is given what we call the molar tooth sign of the gallbladder. What will we do next? Either we will follow the rest of the sequence of the ascending cystoscopy or CT UT. The examiner gave you this one. You see a contrast exervation around the bladder, and see, look here at the urethra, and it extends down. So it may be also association of a urethral injury. Then he gave you this one. This one, look carefully. You were in the correct way. Extraperitoneal, until I show you this one. This is also
Yes.
extraperitoneal, because here this is in the parabolic cutter. The parabolic cutter is extraperitoneal. So this is
So it's a mixed type.
pelvic fracture associated with extraperitoneal bladder injury. The usual treatment of the extraperitoneal bladder injury is conservative, but in this case, because there are multiple, no. In this case, it should be surgical because there are multiple pelvic injuries. This case, You did very well until you insinuated yourself in a big problem. What do you think? After I show you this one, you should tell me I will put also infective process. Very
No, this
difficult.
was illogic. Yes.
Very difficult.
Yes, you
Yeah,
are
I
right.
demarcate you. See, I was giving you 7/8. Then after this word only, because there are large mass. Okay, my
Yes.
colleagues. Second point, see, I wanted to give you a very important information. This is the mass, but what is this? This is the periosteum, the black one, and this is periosteal reaction. I will
Okay, slide.
show you on axial. It's very good
Onion
in
peel.
axial. See, this membrane, black one, is the periosteum. And under it, this is not a mass, this is a periosteal reaction. The mass is this one. So,
Yes.
يعني sure, this is a malignant. At least if you told me 100% this is a malignant, because this
Yes.
is MRI, I will be happy. Okay, you go to differential diagnosis, osteosarcoma and Ewing sarcoma. This is very good. This is coalition. I also demarcate you because you wanted to do after ABCT or MRI. Why? Lateral is very conclusive. Okay, lateral is very conclusive, but you did very well. This one also is a tricky case. This is ACL ganglion cyst associated with ACL abnormal signal, which is a mucoid degeneration. What should we do? We should ask for a history of trauma. Why? Because mucoid degeneration have a conservative treatment. ACL sprain may need a surgical or a laparoscopic, يعني through the endoscopy treatment. Two different way of management. Okay, my colleagues, that is why I bring this case to talk about the management. So
Yes.
we should ask about history of trauma. We should tell if this no trauma, so my diagnosis will be mucoid degeneration, which need no any surgical interference. You did well when you told me there is a ciliary stick appearance. See, my colleagues, it is not classic here. This is just abnormal signal, but يعني it is nice to mention the common sign about the case you are presented with. Thank you so much, Doctora. Really, I so impressed. I think this is the first time for you in our group, and you did very well.
Thank
Next
you so
candidate,
much.
please. Welcome. Next candidate.
Yes, sir,
Any
I'm here.
candidate? Yes, this is Dr. Akila, I think.
Roshni.
Roshni. Oh, yeah. The voice is a familiar voice for us. Welcome, Dr. Roshni.
Thank you, sir.
30 years old male patient presented with a chronic ankle swelling.
Okay. I have been presented with MRI images of 1 foot, axial images of these are the T2 fat set images. Here I can see that there is evidence of abnormal signal intensity lesion noted around the ankle joint. These are returning heterogeneous hyperintense signal with internal hypointense area, and
Yes.
there is evidence of involvement of the ankle joint with internal lucent area, which is
What?
returning abnormal signal within the bone and giving a appearance of erosion. And apart from that, these are extending into the posterior to the ankle joint, involving the Achilles tendon with evidence of joint effusion. And
What's your
in my
definition?
routine practice, this can be a pigmented villonodular synovitis. I will look
What will you do next?
I will look the SWI images to see if there is any evidence of blooming artifact, which will confirm my finding. And I will inform my finding to the referring physician and refer this patient to the orthopedician
How could
for
you
further management.
how could you confirm from MRI this is pigmented villonodular synovitis?
I will look at the SWI images and GR images to confirm that it is giving a blooming artifact.
Which sequence is this again?
GR image.
GR image. Excellent. 8 by 8, Doctora. Really excellent. What's the other differential diagnosis in this case?
The other differential diagnosis in this case, hemophilia can be a possibility.
Yes.
But
Yes. What
but
else?
if patient is a male and the young, then this can be the possibility. Otherwise,
More than excellent. What else?
the treatment is referred to the orthopedic surgeon for synapectomy. This usually go with synapectomy treatment.
8 by 8, Dr. Roshni. More than excellent. 55-year-old female patient with severe acute severe shoulder pain.
Okay, I have been provided with a frontal radiograph of an shoulder, right shoulder. Here I can see that there is an evidence of um, sclerosis and there is a depression noted at the posterior superior aspect of the head of the humerus, and
Yes.
there is also evidence of superior subluxation of the humeral head. This is suggestive of
Your differential. What's your differential?
subacromial impingement, and
About this
in my routine
sclerosis.
practice, I will look. In my routine practice, I will look at the MRI images to see if there is any evidence of rotator cuff tear. And
With MRI, you have only these images.
okay, I have been provided with the coronal MRI images of a shoulder joint. These are the FRCR T2 image. Here I can see there is an abnormal hyperintense lesion within the head of the humerus with surrounding hyperintense signal, and
Yes.
there is evidence of a defect noted within the supraspinatus tendon.
Yes.
So
What's
this
your
is suggestive
diagnosis?
of supraspinatus tendon tear with
What else?
uh, the
Correlate with
this
the
can be
X-ray,
a
please. Correlate with the X-ray, please.
and there is a okay. Can I see the other images?
No, this is only the limited images, and this is conclusive, really. What's your differential?
Okay, this
What
can
else?
be osteomyelitis or
What else?
this I could not make out.
What is your next step?
The next step would refer to the orthopedician for further management and review the previous imaging if available.
Okay, 40 years old female patient with wrist pain.
Okay, I have been provided with axial MRI images of an wrist. Here I can see there is evidence of hyperintense signals are noted within the um, within the tendon of the peroneus longus and brevis.
Okay. What's your differential?
So this suggests a tendinitis with
So do you know the name of this syndrome?
this I forgot the name. Sorry.
Okay, what's your management?
And the management referred to the orthopedician for further management and the surgical treatment.
20 years old female patient with a history of breast lesion.
Okay, I have been provided with the axial CT images of the chest, non-contrast images. Here I can see that there is an expansile lesion noted within the anterior aspect of the rib, and I would like to see, and the lytic lesion are also seen within the multiple vertebral body. So in the patient
Yes.
with a breast cancer, this is likely suggestive of metastasis involvement of the multiple bones. So I will inform
What
my
will you
finding
do
to the
next?
referral physician.
What will you do next?
And I will in my routine practice I will look the lung if there is involvement of the lung and metastasis to the lung. And other okay.
This
so
is the mandible of the
here
same patient.
here there is an also there is an expansion of the ramus of the mandible on the left side. So
Yes.
this is again showing a metastatic involvement secondary to a breast CA, and the bone scan
Look
can
at
be
the
done to see the.
cortex. Look at the cortex, please. Is it intact or not?
Okay, the cortex is eroded on its inferior aspect, and
The cortex is not eroded. What's this
there is
appearance named? Expansion of the mandible and the texture.
there's expansion of the mandible.
And the texture of it.
That this is not the course. This is
Yes. See, this is an MRI of the same patient.
I am provided with the MRI sagittal images of an thoracolumbar spine. Here I can see that there is this is a T1 weighted images, and there is an abnormal low signal intensity lesion noted within multiple thoracic vertebral body with surrounding sclerotic hypointense rim.
Yes, give me some differential diagnosis. Yes, you are in the correct pathway. Yes. What is the other differential diagnosis?
This can be
Other than metastatic. According to
this can
this
be
is sclerotic rim.
the fibrous dysplasia can be one possibility.
More than excellent. More than excellent. Okay. 25-year-old male patient with fever and back pain.
Okay, I have been provided with the sagittal.
Yes.
I have been provided with the sagittal MRI images of an lumbosacral spine, T2 weighted images. Here I can see that there is an evidence of abnormal high signal intensity noted within the paravertebral muscle, and also the perivertebral muscle.
Yes.
And there is evidence of a large collection within the epidural space.
Excellent. More than excellent. This is the point.
So
Yes.
this. So these are the, I think, DW images which is showing a diffusion restriction in the posterior right paravertebral region, also within the spinal canal and in the right perivertebral muscle. So this is the gist of multifocal abscess with spinal extension and epidural
Give me
abscess.
differential because Zoom will shut down. Give me differential.
The differential would be a second to infective etiology with epidural abscess and paravertebral and perivertebral abscesses.
What is the next step? Most important next step.
I will immediately inform my finding to the referring physician, and this patient this patient refer to the spinal surgical team, and this patient require a drainage of the abscess collection, and in this I will look the spinal cord if it is normal. I could not see it.